Hello and welcome. My name is Chris Rowena, and I'm the lead communications analyst at HCAI Health Workforce. I'm so glad you could join us today for the fourth in our series of Rural Health Transformation Program, or RHTP, listening sessions. Today's session is focused on sustainable access and rural health. Our aim is to hear directly from you, your needs, your challenges, and your ideas to ensure that California's planning for the RHTP reflects the realities of rural communities. Before we begin, just a few quick notes to help you get the most out of today's session. Number one, the platform. This session is hosted on Zoom webinar. Your controls are in the toolbar at the bottom of your screen. Number two, we are using the Q&A feature at the bottom of your screen for all comments and feedback. Please type your input at any time. Comments will be moderated before they appear publicly. And number three, today's session is being recorded. The recording will be available on our website within 5 business days. Let's talk a little bit about our session purpose and why we're here. We're here to provide a high-level overview of the program's goals and structure, to share early survey findings to show how your feedback is already informing our approach, and to listen to your thoughts, experiences, and ideas for a topic-specific deep dive. HCAI's commitment to you today is we're here primarily to listen, not to present. Your feedback will influence how we design this initiative, and this is just the beginning of an ongoing conversation. And I'd like to remind you again, please use the Q&A feature to answer questions that we're going to give you at the end, or to ask any questions or comments that you have. And just to re-emphasize that this is a listening session, not a technical assistance webinar. So we're primarily here not to answer a bunch of questions, but to hear from you about your thoughts and input. And with that, it is my pleasure to introduce our Senior Policy Advisor for Health Workforce, Hovik Kosrovian, who will be presenting today.
Thanks, Chris. Welcome, everybody. Really excited to have all of you here to join us for this fourth session today. So I know many of you have probably been on other sessions, so hopefully you aren't getting sick of hearing from us. And hearing these first few slides, some of the basics of the Rural Health Transformation Program, and share that. So again, appreciate everyone being there to listen to us. So I wanted to first initially talk about rural health in California in general and rurality in California. So with the notice of funding opportunity coming out from CMS a couple of weeks ago, we finally knew the definition for rural health. And we were able to kind of look at that and show really California and its rurality. Nationally, I'm sure many of you heard everyone always hears California and talks about rural, and they're like, really, California, is it rural? We actually are quite rural. We're very rural. About 82% of California is a rural census tract. And again, census tract is a definition from U.S. Census for measuring where people live and many of the data points that they collect on everyone. About 2.8 million people live in rural census tracts in California. It's pretty significant. It's almost, I think it's about more than 20 other states have for their entire state. So California has quite a significant number of residents living in our rural communities. About 57 of the 58 counties have rural populations. And how the healthcare infrastructure works in those rural communities, there's a really large, I don't want to say large network, but there's a number of facilities there, all who work really well together, are integrated into supporting access for those communities. But again, this program itself, and we're going to talk about it later, is really key to supporting those providers and those facilities and that infrastructure and to strengthen it. And that's what really today's discussion is going to be about. There's about 279 rural health clinics, and those are the certified clinics that CMS approves. There's about 296 federally qualified health center sites in rural communities. As well as about 76 rural hospitals. These are the critical access hospitals, small rural hospitals, some larger hospitals, but this is really the core infrastructure for that hospital system in these rural communities. And lastly, we know there's significant need in these communities for access. We do the health professional shortage areas, which are federal designations that HCAI oversees. And in primary care, about 76% of all rural census tracts are in a health professional shortage area. So it's pretty significant, and it really outlines the need for additional access and the issues that these communities really face in trying to address this. Next slide. So I'm going to give a little background on the program overview for the Rural Health Transformation Program. Everyone's probably familiar with HR1 at this point and the pretty devastating cuts that were in there for a lot of services, including Medicaid. This program, if you kind of take a look at it as a positive spin, is that silver lining within the bill. They appropriated 50 billion for this rural health transformation program. Now that's across the entire country, all 50 states. So when you talk about California, again, I won't go into kind of like with some of the budget details. It's a little bit more difficult with that level of funding, but again, it's a great opportunity for us to really drive some transformative objectives here for rural health. So within that form, there's five main goals which are outlined here. Today we're talking about sustainable access, which, if you look at it, is one of the goals that really encompasses just about everything else within the strategic goal framework. Sustainable access means you have a workforce that's there for you. You're being innovative and trying to figure out how to reduce costs and really work towards sustainability. You're using tech innovation to achieve some of that and cost savings. And then you're looking to make their community healthy again through chronic disease prevention and other kind of preventative objectives. So it's really, when you look at sustainable access, it really incorporates all of those points. So today's discussion, we're really looking forward to hearing some comments and feedback about what can really work in these rural communities to sustain what's there, to strengthen what's there, and to ensure that all the people that live in these rural communities have access to care of all kinds. And so we're not looking at just one specific type of care. We're talking about primary care, maternal health, behavioral health, oral health, specialty care. So all of that is on the table here to really discuss how we could strengthen that structure. So within these goals, there's a list of activities we'll see in a little bit. The state has to choose at least three of those activities that align with these five goals and to show how we're going to achieve these five goals. The goal here again is with this funding, and CMS was very clear, the federal government's been very clear, these funds are not to supplant or replace lost funds or existing Medicaid resources or Medicare. They're here to support and change how the system works to ensure long-term sustainability. And that's why we're here again to support these communities, to ensure access, quality, and outcomes are done through this transformative proposal and program. So I really want to key in on that and how can we make these changes. Go ahead, next slide. So the funding distribution, this is where it gets a little trickier. I'll try not to go too much to the weeds. 50 billion total across the country. Half of that, 25 billion, is split evenly among all 50 states. So every state that has an approved application will receive an even share. So it's 100 million a year for 5 years, and that's the minimum threshold of each state will receive based on that first half of that 25 billion. So again, 500 million over 5 years, which, and all of you here, are familiar with California with the population size we have, with the large infrastructure we have. 100 million a year is not very much to really transform rural health. So that's where we have to be really strategic and potentially even identify key programs, pilots, and tests to see what works, and to then we can use that to say we know what works now. We want to implement that across the state. We want to have these scales of economy to really be able to support the full system. But again, 100 million is not a lot of money. So we're really trying to be strategic here and try to see what's the most effective way to sustain access and ensure providers are there for the long term for the population. The other 25 billion, the other half, is distributed to the states based on specific scoring criteria. It goes through specific factors such as the percentage of population that's rural, the number of facilities, the number of distressed hospitals in your state, as well as other factors that connect to different legislative and policy changes that have been implemented, where you rank as far as different types of data-driven factors. It's quite the list, but again, what it does is enables states to look at, enables CMS to distribute funding based on that need. Now, one of the things in this proposal, and CMS has outlined that in their notice of funding, is they want each state to apply as though they were going to get 200 million each year, so a billion for the 5 years. Once the state applies for that amount, and November 5th is the due date, CMS will then come back to you, score your application, and tell you how much you actually are eligible to receive. At that point, we go back and revise our proposal and have to potentially reduce some of the activities to see what fits within that budget. So again, this is still one of the first steps, but there's still a lot of gray areas that we still aren't clear yet. So any kind of proposal that as we develop this and submit it November 5th is going to have changes after that fact in November. So again, that is why a lot of these times when we're talking here, we want to have specific answers to what are we actually going to put into the proposal, because a lot of that is still in the works, and it will be in the works even after submission of the application. But wanted to just make sure that was kind of clear in the beginning here. Next slide, please. So we talked about the 11 uses of funds. So these are the specific activities that states have to choose. Again, they have to pick at least three. They don't have to do all 11. Yeah, you could do any combination. Again, this also goes back to that funding amount. So we'll have our initial funding that we with the 200 million that we apply for, knowing potentially that can get reduced once the application is scored. So then that's where we work through. So many of these activities connect to different strategic goals. So you'll see here a number of them connect to today's discussion about sustainable access. And this is where we talk about appropriate care availability. Workforce even connects to it, even though we just recently, yesterday had our workforce session. Workforce kind of connects to everything because that's all about sustainable access if you have that workforce. There's also IT advances and technical assistance. A lot of these connect to sustainable access. So we really want to hear some of your feedback and thoughts on how we can potentially incorporate those and what works, what doesn't work in these rural communities. Because we understand it's not the same across the entire state. Each rural community is unique, and what might work for someone in rural Imperial County might not work for someone in Modoc or Siskiyou. So we really want to make sure we address the needs of those communities, not just have like a cookie cutter and we think it's going to work. We want to make sure it's unique to the state. Go ahead to the next slide. So again, talking about that timeline, we mentioned mid-September, the notice got released. We're, very, very short timeline. We can't stress enough how quickly this application has to be put together. November 5th, the due date, knowing that, again, it's a quite significant, extensive application that includes many, like details, outcome measures, evaluation plans, data components. So we have even less time than November 5th to put it together. We realistically have about a little less than a month to put it all together. So you can understand. And thanks. I also want to say how appreciative we are of everybody being so patient with us as we work through this and send out communications and receive your input. Just to let you know, we are looking at all your input and taking it into account and following up when we have questions. So really wanted to appreciate that from everybody. The other thing I wanted to bring up is, again, as we move forward, November 5th is that deadline, and decisions will be made by CMS on December 31st. As we move forward in that situation, January 1st is when it will start, the funding itself, and then we will have the implementation of that right away after that. So I wanted to make sure we move forward with all that. Go to the next slide. So one of the things we want to talk about, again, we did a survey a couple weeks ago. We were excited to see about 350 people respond, and it was really great to see the breadth of the responses there. We had 43% of non-providers, and 57% were healthcare providers, meaning facilities, organizations that provide healthcare, and individuals, the providers. So we really wanted to really highlight this, say we got an amazing number of responses, and we're really excited to have this input and to really share that with everybody here today. So go to the next slide. So again, sustainable access is what we're here about. We're here for today. So one of the things we want to talk about is what is sustainable access, and to really sum it up, the goal is about ensuring rural residents have reliable long-term access to essential health services no matter where they live. So there's certain areas of focus there. There's four things that CMS has really pointed out. Facility sustainability is one of those that kind of goes into sustainable access. Regional collaboration is another one. Service line optimization and emergency specialty care. Those are four areas that CMS focused on in the notice of funding. There are also areas that are called out as far as specific points that yield additional points in the application and are effective in aligning with some of the goals that CMS has. So why does this matter in rural communities? So there's a number of things we know about what's going on in rural communities now. There's a lot of facilities, hospitals that are in trouble financially. They face risk of closure. We see it every day. We see hospitals that are either at the brink of closure or are actually are planning on closing, and in the process of it, how do we help them? How do we help these facilities? How do we stop that from growing? And how do we ensure that in the long run they're able to maintain the services for that community? Because that is the most important thing that we're trying to address here. Um, we also look at for certain things about long travel distances. We know for specialty care, it's very difficult in rural communities to access that. Individuals have to travel 1, 2, 3 hours away to access basic specialty care services. And we know sustainable access that it means getting the services you need where you are, not necessarily worrying about, oh, can I get there? I don't have a car. There's no public transportation available. How do I get there? And pausing, getting help, waiting for too long, and then you get to the point where it's you're in a dire situation. So we really want to make sure we address that. And this relates back to a few of those funding categories that are outlined here again with appropriate care availability, certain expenditures. There's also limits on some of these costs, so we really want to stress that. So not everything can be fixed with just funding someone to be maintained for another couple of years. It's really about how we look at that, how they're structured, and how we can support them. Next slide. So we have through the survey we saw a list of specific areas that really came up to the front from the responses. And we really wanted to highlight that here. So you can see here from the survey responses, we had coordinated care with other providers to regionalize shared services, which is really important, and we understand that because that helps expand access. There was a few comments about formal hub and spoke networks that we really understand can be really effective in specialty care and perinatal and complex behavioral health. So it's really great to hear about that, and we really want to learn more about those and potentially what's been working and what are some potential models that can be leaned on for to learn from. Telehealth has been coming up across the board. Again, telehealth here for sustainable access, telehealth on the innovation and technical side of things. So really looking at how telehealth can fill in those specialty gaps. So it's great to hear and have that confirmation from everyone that is really key. And we also heard about e-consult, cross-training. So again, going back to workforce is key for sustainability. So again, it's great to see how workforce coordinates with that and how we can expand that and ensure workforce is there. They're working at the top of their licensure or top of their scope, as well as getting cross-trained and upskilled to provide additional services. So it's really key to have that availability, as well as things like ambulatory care, emergency services. They were all important in the survey. It was great to hear that. Next slide. So some of the things we saw within this for kind of like looking at the key takeaways from the survey and the input we received. There was regional coordination. Again, we talked about the hub and spoke, sharing services, coordinating care, and that's one of the things that's really come up continuously from CMS is these collaborative models, regional collaborative models, and learning from systems that have best practices and are successful. We also looked at how we support and elevate primary care, again, through collaboration, integrated care. A lot of different input we received here, and we really want to be able to hear from you all today. What are some additional paths? What are things that work? What are some inputs that you want to provide to us that we should really consider? And looking through the rest of them as well, transportation and access is always key. What's potentially can be done there. Financial sustainability, which is a very big issue. We know that HCAI itself, a couple of years ago, we were there with our distressed hospital loan payment program to really support the hospitals. But we know more is needed on the sustainability part and how do we impact that within this rural health transformation program, knowing clearly CMS has outlined the funds are not there to support the direct sustainability. So it's not to keep operating for facilities for the next couple of years. It's to help them transform and be more efficient so they can survive for 20, 30, 50, 100 years from now. Infrastructure upgrades are a little bit more limited in the rural health transformation program. There's some opportunities there, but again, CMS has very strict parameters around the funding for that, so there's a little less leeway there. And lastly, emergency services, which has come up quite a bit from CMS and from other states that we've talked to, and looking at how emergency services can help expand that access, support individuals at their home, and try to reduce the cost of going to emergency rooms when some things could be taken care of remotely. So really, those are the key elements that we heard to ensure the sustainable access. Next slide. So here's some questions we really wanted to be to really want to ask everybody in post session to be heard, to have us give us input about what you think on sustainable, our potential opportunities. Happy to, as we get your comments, happy to address them through this, or we also are taking them in and logging them to ensure that we understand what you want, what you need. So as we build our proposal, we address those. So 4 questions here that I really want to hear from everybody. One is, again, we're talking about those partnerships and what steps have been taken that you know of to explore some of these affiliate partnerships with existing facilities, again, to kind of have that cost sharing and sharing of the expenses to ensure sustainability. So how are some of these regional networks been developed? What have you seen as successful? What have you seen that potentially we can learn from and know not to potentially incorporate into any potential proposals? Again, what are some challenges? Again, we go back to infrastructure, technology. We had a session on technology, but this is again connected to sustainability because we know technology is a great use to make it more efficient, make your end-to-end revenue cycle much more efficient, make your electronic health record process more efficient so that you can move forward and save operating costs from there as well. So what are some challenges for folks that they see in upgrading that area? And third, what are some strategies or partnerships for rural providers to maintain that sustainability while you share those services across regions? And then lastly, how can rural communities best align care delivery to meet the local needs while through improving access to emergency services and specialties? So we know there's areas that just don't have the volume to address some specialty care and even some basic services as well. But those populations need those services. So how do we address them? What are some potential ways that you've seen that helps deliver that while ensuring that the facilities that are there can continue to survive through that coordination and delivering those services through their own networks? So I really wanted to bring that up to everybody and address those. So happy to kind of take some of the comments and suggestions and discuss them.
All right, thank you, Hovik. As we move into this listening portion of the session, which really is the heart of today's conversation, I want to remind you, please use the Q&A button in the toolbar at the bottom of your screen to type your input to our questions or any general comments or questions that you have. And as Hovik mentioned, this is a listening session. Our goal is to gather your input on everything we are presenting, and in particular, your input on these 4 questions here today. Reminder, some of the details of the program are still in development, so we may not have all of the information yet. And starting to see some questions coming in and some comments. We'll give a minute or two for our system to catch up. And also want to mention that all of these sessions are being recorded and will be on our website within 5 days of each session. We will be putting our resources online and will be available. Also, if turns out that you think of something later today or tomorrow, that's okay. Go ahead and email us at calsor, CALSORH at hci.ca.gov if you do think of something after this session today. So one of the questions that was mentioned already is a question about the slide decks. And again, 5 days for the recordings. We'll also put the slide decks up at the same time with that. So first one for you, Hovik. Costs are the biggest challenge to upgrading current technology infrastructure that include obtaining EHR that has interoperability, support data collection, tracking and reporting on outcome measures. Small FQHCs do not have the capital to upgrade EHRs.
Thanks for that. Yeah, so that's a good point, and it's something that we've been hearing a lot of, and we understand. So there's a lot rural communities. Very few have very large systems and organizations in those communities to really support some of these more expensive technology updates. So one of the things we're exploring, and we would love to hear more from folks, whether how's the potential for that to work? Have they tried it before? Is these collaborations, these partnerships in these regions to have, whether it's multiple organizations, facilities working together to share those costs or to have almost like a seed funding to develop that infrastructure, and then they maintain it through this kind of coordinated partnership. So those are things that we want to help. We understand, yeah, we can't expect a small clinic to be able to just completely transform how their IT infrastructure. But we know it's a huge lift of a burden if they have that technology. It simplifies a lot of things. It also potentially helps out the workforce there, the clinicians, because now they have much more efficient use of their time. They have records more quickly available. They have the ability to bill quicker, and overall it helps the whole structure. So uh, we understand that, and that's one of the things we're trying to determine what's the best use of supporting some changes in IT infrastructure through these kind of collaborative opportunities with multiple organizations, rather than doing having a program where we there's a funding for one organization only, and the issue is they just don't have the structure to implement it and to oversee it. So we really do want to hear from folks on what are some ways to really address that through this kind of coordinated communities working together. Uh, to potentially not just share the cost, but again to work together to support that infrastructure. We understand it's very challenging for some smaller clinics to support that. So we are looking into how we can build that out within the proposal.
Thank you, Hovik. Next comment comes from Andrea Mitchell, and it's in regards to question one. As an FQHC affiliated with a large academic medical center, we are partnering with two of the three rural hospitals in areas we serve by utilizing that hospital as a rotation site for a future family medicine residency program. We are concerned about the hospital sustainability as one is nearing closure and the other is having challenges.
Andrea, yeah. So this is where that challenge comes in, where we really want to expand the infrastructure. And when we talked about workforce yesterday, potentially, adding the new like trainings and opportunities for individuals to train in rural communities, because that works when they train there, they generally stay there. Um, but also wanted to we understand the challenges there, because you do need uh, the reliability. You need to know that the organizations are going to be there long term when you develop some of these programs, like a residency program. So one of the things that we really want to learn is what are the issues that these facilities, in this case, you're talking about the hospital, like face, and what can we do within this program to support the structure they have to make it more efficient, to be more cost effective, and to ensure they have financial sustainability. Because without that, yeah, it's going to be hard to have a school say, oh, we're going to have a residency program where they have clinical training at those sites, because they need to ensure their students have access to those. They can't worry about a hospital closing, and then 20 nurses now no longer have a place to train so they can graduate. Uh, so it's really key for us to understand. One of the things we really want to do here is build out a system of determining what the situation is in these communities, not just fiscally, but also access wise. What do they need for all sorts of the full infrastructure of that community? So we're looking at how we can assess that community by community, because we know across the state it's going to be different for everybody. And once we really understand that, what's the next step we could take to address what are some areas that we know are quick to fix? Quick again, meaning next 5 years, because we understand some things just can't be fixed over 5 years, but we want to get people on the right path. So it is difficult. One of the things we're hoping is that we can with these funds we can pinpoint some initial areas to support, to know that these facilities can now have that sustainability. So then that opens it up on the workforce side too, because that's a huge component. You need the sustainability of these facilities in order to ensure the workforce is comfortable working, like starting a job there, having training there. So that's part of this process for us. I don't have a perfect answer for like this is exactly what we're going to do, because we're still working on the development of this. But one of the things we do want to do is be able to assess what's going on, so then we can, all right, here's what we can do. Or in some cases, look, the data shows there's not much we can do. What can we revise or optimize to ensure that there's still access there given the situation? So there's a lot to still kind of go through with this, but we're really hoping that it's very data driven, and a lot of the feedback is from everyone here helps support us in what we think is the appropriate path to take.
So Vic, this next one is probably on a similar theme. Funding for EHRs and to implement changes in policies uh, and procedures and training is the biggest barrier to upgrades, especially for small providers. The transaction cost for data sharing can be expensive too.
Yeah, and this is kind of what we've heard as well. So I think this goes back to that kind of regional coordination and collaboration, and what can we do in that area, so everyone's working together, and we're able to support these changes and have them continue on once this funding is gone in 5 years. That's really key, and that's what we want to learn. So if others in this session have any input on what you've seen that potentially has worked with partnerships and implementing infrastructure, IT infrastructure changes, EHR changes, we really love to hear about that. We're diligently looking. We have, again, because we have such limited time to develop this. You're all really I can't tell you how appreciative we are with everyone's input and help. So if you do have these examples of, hey, we did this and it worked in our community, even if it's an urban community, please share them, because it could always be revised and looked at with a rural lens. So these are the opportunities we want to learn from you. So yeah, we understand. We want to look at how, like, that, again, that cost could be shared, how we can kind of have that initial kind of seed funding to support those changes. But again, we don't want to just be able to say, here you go, like, we're going to help you pay to fix this, but then they're on their own. They have, like, they can't sustain it. We want to make sure it's sustainable. So we're looking for, like, some potential models or pilots others have seen that have worked in, even if it's not in California, if you've seen it in other states. A lot of times some of these rural, like a lot of the rural states, are very innovative. Out of survival, they have to be. So it's great to learn from them too.
All right, thank you. John Blaine says, and let's see, yeah, why is the expected California portion of this distribution to providers only 100 or 200 million? That would indicate only 9 to 18% of the funds from the legislation would be allocated each year to this effort. What am I missing?
Not much, John. It's really it's some politics in the background, I'm sure, but really it's that 100 million is the baseline amount. Anything in addition to that is based on the scoring factors, and the notice of funding. I don't know if everyone's seen it. It's about 100, I think 130 pages or so. It outlines the scoring factors for that other 25 billion. Now, what I will say, and CMS has said, that other second half of that 25 billion does not have to be distributed evenly across the states. They've just said the maximum that anyone could receive right now is 200 million if they get basically a perfect score. What they have said is, if once the states are all scored and that other 25 billion is not fully spent, there is opportunity for states to ask for more funding. So one of the things we really want to address in our proposal is really innovative ways to transform rural health and really push the CMS. California is very large. 200 million is not going to be enough to really get to do everything across the entire state. But here's opportunities we have to implement some of these proposals. And if more funding was available, we could implement it in many more places and potentially across the entire state. So we do want to have that availability too, to kind of explain that to CMS. So there is some opportunity potentially to go above 200 million. Now, I wouldn't bet the farm on it. It's not a guarantee. It's just, and there's a lot of factors behind it, so we can't say, like, for sure. If we put together, like, the greatest proposal that you've ever heard, then we will get over 200 million. But again, a lot of it depends on CMS decisions and scoring. So at this point, they just asked every state to apply at the 200 million, and then they will decide what that additional above the 100 million baseline states will get, and who might get more, who might get less. It's still really up in the air.
All right, thank you, John, for that question, and Hovik for that response. Next one is an anonymous comment. Health providers that are primarily funded by Medi-Cal and Medicare without commercial insurance can be financially at risk, especially when there's an unexpected one-time cost that arises and cannot be reimbursed in a timely manner by government payers. Late payments end up being expensive because providers may need to seek lines of credit and other options to meet payroll, etc.
Yeah. So what I'll say is, one of the things that we're really looking at is how can technology help make this more efficient? Um, we've heard from a number of facilities that, in rural areas, the end-to-end revenue cycle could take a long time. Denials are very high. Um, and so what are opportunities there for potential solutions? So that's one of the things if others have tried different solutions to make it work, uh, we'd love to hear about it. We're pursuing, we're doing research. We're talking to different facilities to really learn what they've tried to explore, what potentially has worked, what hasn't worked. Sometimes knowing what doesn't work is even better than what does work because we can really understand, why didn't it work and what potentially was the way to correct that. Um, so there's always a risk with the payment structure, and one of the things we do want to look at, 'cause this is where sustainable access comes in, like this specific goal itself, is how can we support facilities in speeding up that process. Now, I can't say, if it's all red tape and bureaucracy. I wish I could say we could fix that, but definitely it's an opportunity for us, at least within the state, to know if it's something that is within our control, or is it something that we can bring up to CMS or potentially resolve with the changes in the technology of how those are done. So it's definitely something that we really want to hear from you of what are the core factors of that and what have you seen that potentially could work.
All right, thank you. Question that we have, what helps bring health workers to rural communities and what makes them want to stay?
Yeah, so really, I know we talked about a little bit on workforce yesterday, but really want to understand, yeah, again, with sustainable access, you have to have the workforce. Obviously, if you don't have the workforce, it's going to be very difficult to stay in business, and make sure you're addressing the community's needs. So for those that potentially have input on that, to really like let us know what are some things that you've seen work. We've heard a few folks and from the previous sessions about when people come into that community for as a provider. Housing is an issue. They can't, it's difficult to find a place to live. If they have family members, whether it's a partner or spouse, will that person have the ability to find their own job? So really looking for novel ideas. I've heard from facilities and clinics that when they get a new provider and they have a block party basically, and welcome that person and have that person connect to the community. Again, that's not really something that would go in a rural transformation proposal, but it's some opportunities of what are there other methods of like what can be done in those communities to help engage that individual that comes to your works at your facility to be part of the community, and then make what they do more efficient and simpler, and whether that's through technology, whether that's through advances in how documentation is done, how billing is done, how the support staff, so allied health folks that are working with, whether it's a physician or advanced practice provider, we have the community health workers, we have peers, we have the LVNs. How can they support them? So we know having a care team helps everyone out. It reduces the burnout, reduces the stress on one person to do it all. And how does that work into these factors? How does that work into potential partnerships that you have of sharing resources, sharing labor? Because we understand some rural communities also, you might not have enough population to sustain one provider, but you might have multiple facilities working together in a region that can sustain that provider and ensure that they have their work that they want to do, and they're getting done what they want, and then that access still remains. So those are some things that we really want to understand and then be able to address through this proposal as well.
All right, thank you, Hovik, for that. Shakan says rural communities face persistent gaps in access and provider retention. As a physician who began practicing in rural California during the pandemic, I witnessed both the barriers for patients and the strains on clinics. At Enlighten Med, we've partnered with RHCs and FQHCs to expand capacity by embedding clinicians and implementing advanced primary care management and remote patient monitoring. These approaches have improved follow-up after hospitalization, supported chronic disease management, and reduced wait times. Integrating APCM and RPM into rural health workflows offers a practical way to strengthen local systems and ensure care remains accessible and sustainable.
Thanks, Mr. Khan. Yeah, it's a great point. Really, that's perfect input. That's great to hear because we have been hearing quite a bit from other states as well about the RPMs and their benefits, and potentially looking at how we can help implement that here in the state, and what are some opportunities? Like, there are some areas there that really could support and ensure that access, regardless of like where that individual is, that those are tools that we can use to ensure these clinics are able to support them. So really, yeah, I just wanted to really appreciate that comment.
Next one, supporting community healthcare settings such as pharmacies through technological innovations and advancements, for example, interoperability and data sharing, payments for the provisions of care services, as well as removing existing administrative and scope barriers, will only enhance care coordination and collaboration among community healthcare providers and settings and improve access outcomes for Californians.
Thank you for that comment. Yeah, we I don't think, yeah, we definitely agree that there's certain community settings, again talking about like community pharmacies, um, that really could pave the way for some of these innovative ideas of how we can use the infrastructure that's already there and expand them. So CMS, one of the things they've continually pointed out, whether it's through the webinars or through their guidance, is using what's there already and seeing how that can be expanded to support the community. They've mentioned pharmacies, they mentioned emergency medicine services, and CNCHW is whether they go to those communities, they go to those individuals who request help or just need to check up, and they do it at their home, rather than having them have to travel an hour away. And those services are still maintained through that specific regional site. So there are definitely areas where we think like, yeah, there's settings that already are there that could potentially support, and there's technology that can enhance that support. And then looking at potentially what other kind of provider types are there that can work at the full scope of their license, as well as enhance their abilities through upskilling. So settings that really I think there's a benefit for. So really appreciate that comment of like having us consider that.
Thank you. Uh, Next one is better data interoperability is needed between rural community-based organizations and DSNPs to assess levels of integration, service delivery, and care coordination. The SCAN Foundation recommends that technical assistance to support better data integration and bidirectional data sharing between health plans and CBOs be prioritized in California's application.
Thank you for that. I know, yeah, I've seen the DNSPs brought up a couple of times. Really appreciate that feedback. Like, there's a number of different things we're looking at. So if there's potentially an opportunity, I don't know who put that message in there, but to be able to submit more information to us, that'd be really great. I know we'll have like our email address at the end here, but there's a lot of different things we're looking at around interoperability, to ensure that there's this coordination around with all these facilities. Always got, I don't want to keep beating the same drum, but it's all about that sustainable access. So what can we do through a lot of these really innovative ways using technology to make sure that we are increasing access while still having those facilities, those providers be able to maintain their current structure. So always looking for those new ideas. So that, yeah, I appreciate that input.
All right. And just note, we're really appreciate everybody's participation so far. We're moving along and getting close to being out of time today, but we do have time for some more questions and comments. Uh, Take a look and see what we've got still left in the queue.
And yeah, please, yeah, don't be shy about giving us potential like links or resources that you think may be effective for us to kind of dive into and research. Um, Again, we can never have enough input from everybody, because this is really important that we ensure we're addressing everyone's needs in these rural communities. So again, it's because it's a short timeline that we have to build all this out. The more information we can get from everybody, just easier it makes it for us to really make sure we heard from everybody, and we are addressing what the needs are of these communities. So just, yeah, really appreciate as much information as you provide.
All right, thank you. Take a look through. I just want to remind everybody too, that again, if you think of something tomorrow, please email it to us at calsor@hci.ca.gov, and that will we'll be able to take your input that way as well. Would appreciate remembering we have a short timeline on that, so any additional feedback, please get that in within the next couple of days. Would be tremendously helpful for us. Um, all
Do you want
right.
to go to the slide with the link?
Yeah, let's move on. So, just really want to thank everybody for your participation today. Bring lots of thoughtful comments and questions. Hovik, thank you for your expertise. And want to let everybody know that we've captured all of your inputs today, all of your questions, even those that weren't discussed live today. Every bit of information that you gave us today, we have captured and are going to be using in our work as we proceed forward. Again, please email us if anything else comes up at calsort at hci.ca.gov. And your feedback really is an essential part of shaping California's plan for the RHTP. Before we go today, I just want to encourage you to visit our website and see what other resources and everything that HCAI offers. We appreciate your collaboration and partnership. We would love for you to follow us on social media, and you've got a number of channels there for you to be able to do that. Tag us on any great work that you're doing that continues to make California a healthier place to live. We also would really love you to sign up for our monthly newsletter. You can follow this link here, or you can click on subscribe on our website. And just make sure that you select any of the options under the health workforce heading, and you will be added to that monthly newsletter, and we'll stay up to date with everything that we have. And go ahead and here's contact information that you can contact us with. And once again, just want to remind everybody that everything that was submitted, we captured. Some of the questions we're looking to make sure that we have the right answer before we respond to them. And so we may not have been able to get to everything today that was discussed, but we definitely captured it all and we were taking it all into consideration. So we really do appreciate your participation with us today. We ask that you continue to share this opportunity with others in your network. We do have one more session coming up tomorrow at 10 a.m. That's session 5. And so this does conclude session 4, Sustainable Access for the RHTP listening sessions. Thank you again for joining us, and we look forward to continuing the conversation in the session ahead. Thank you so much and have a wonderful day.